Hospital, would like to welcome Dr. Satish Khadilkar for our virtual patient awareness programs with question and answer on multiple sclerosis. Over to you, ma'am.
Okay, fine. Great. Can we have the first slide? Okay. So namaskar, and I welcome all of you here today. I take this opportunity to, on the behalf of the MSSI Managing Committee, MSSI Managing Committee of the Mumbai Chapter, and the staff of the MSSI office of Mumbai, to welcome all of you here to in celebration of the 35th year of MSSI in Mumbai. And we realized we started having webinars on MS and the different aspects, and we realized that what happened was, though the wonderful awareness and knowledge was given to our audience, our MSPs, they never got a chance to actually ask questions and to be given replies. And today we have a very eminent neurologist. He's been very kindly, he's kind enough to associate himself with MSSI Mumbai Chapter very, very closely. And today we have Dr. Satish Khadilkar with us. If you were to look at the slide that I have projected, he has got all the degrees that he could possibly get, postgraduate degrees in our country, in neurology, and he's a fellow of many eminent international organizations in neurology, and he's of course got the fellowship of the Royal College of Physicians, London, a very esteemed fellowship. So it absolutely doesn't come as a surprise that he was a professor, HOD of head of Department of Neurology, Grand Medical College, JJ Group of Hospitals, and currently he is occupying a very estimable seat of the Dean Academics of Bombay Hospital and Research Center. Now, I don't know, while I'm saying this, perhaps there are a few more publications to his credit, but he has about 192 internationally acclaimed articles which have been published in his on subjects. Dr. Khadilkar, I'm sorry, I really could not read 102 articles, but I did read all the captions, and I was amazed because the articles varied from anything like from multiple sclerosis to clinical genetics. Wonderful, sir. It's so nice to see how much work you have done, scientific work you have done in your field. And of course, naturally, you got published in two of the scientific books. You have spoken and shared numerous lectures and seminars. And now, because of these COVID times and the way we need to present now online, all the webinars. So, sir, this is a wonderful opportunity for all our MSPs to interact with you. We tried and made it a little simpler by asking the MSPs to send us the questions in advance. And I thought maybe if we were to display the questions, everybody could read them, and then you could probably answer those. So, if we can, with your permission, if we can start, then
yes,
then I will show you the first question.
Yes.
And because of your academic, prowess and your interest, the first question is very academic.
Yeah. I think before we take the question,
okay,
if you just give me 30 seconds.
Right.
First of all, I would like to thank you for being here and conducting this session. And I remember my days at Shushrusha where I absolutely admire the work that you were doing and you are doing there
at that time,
and,
yes.
Which is absolutely fascinating work that you have done. And about the MSSI also, I think I've always been very, very happy to be associated with the MSSI because the way the people are, particularly Mrs.
Absolutely.
Chitnis. I
Oh,
originally
yes.
came in contact with her, and then everyone else. And I think their enthusiasm makes you makes you want to be part of it. So I'm very, very happy here. It's
Thank you,
not
sir.
that
I mean,
I mean, this is one of the special organizations. Um, so very
thank
happy.
you, sir.
One thing. The second thing is in
Your,
these questions, question and answer sessions,
right, sir.
often people sort of want neurological advice on this forum, but I think
Right,
that is slightly incorrect because
correct.
each one of them will have their own neurologist, so they can go back to that neurologist and discuss actually what they should do. So this session that Dr. Bhatkande and I will be conducting is not to provide medical treatment to people on this forum, but to make them more aware of the illness, make them more aware about uh, what they have, what they should be doing in general, and then they can go back with that knowledge to the neurologist who is treating them and then take it
Absolutely.
from then. So that's something that I wanted to stress. Yeah,
Absolutely, sir. In
yeah.
fact, that is
So
what
I
we also carry out at MSSI itself, sir. We do
correct.
not, we do not ask, we always ask our patients to go back to their own neurologist
Absolutely.
and, and connect with them
Absolutely.
because I think that is,
Yeah.
that's ethical.
Yeah.
That's
Yeah,
ethical
and this
and
sort of
correct.
session is to enhance their knowledge about
Absolutely.
the condition, and then they can go back to
Right, sir. Now,
whoever is
what has
treating. Yeah.
happened is it's more like case studies and they have asked personal questions. But I think, sir, what you're very rightly, maybe you could make it more generic so that,
Yes.
there's no, yes. Should
Yes.
I go on
So
to
I
the first
think
question, sir?
yes, yes. Please, we can
Yeah,
start
okay.
now. Yeah.
So this is actually a very academic set of questions, and the MSP has asked can the type of multiple sclerosis be determined right in the onset of the disease? And what is the difference between primary, progressive and secondary progressive? Are the treatments the same or do they vary? And can primary progressive MS actually change into, that means can they actually change into one another? And so I would like to just add another little question here. Is
Mhm.
there an entity called as relapsing secondary progressive? So, sir,
Yeah. Yeah.
over to
Yeah.
you.
I think very, very good questions. I think um, very good questions. See, basically, um, it may not be wrong to say that you need to see the patient over a period of time before you can decide whether it's the primary progressive MS or it is the RRMS or relapsing remitting MS. However, some guidelines are there. First one is that RRMS is far, far more common than the progressive MS. So when the question of MS starts, you are much more likely to be having an RRMS. That's number one, just by the commonness. Two, if the first attack comes very quickly, in a couple of days it builds, then it stabilizes, it is more likely that this will then get better, and this is RRMS. In the primary progressive MS, hardly ever an attack builds like that in a day or two. The disease starts simmering from the word go. Slowly, 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 week after week, month after month, the disability comes. So the tempo of the disease tells you. The first symptom tells you. If it's an optic neuritis, it is more likely to be RRMS. If it's a cerebellar ataxia, it's more likely to be an RRMS. On the other hand, if it's a subacute progressive spinal cord dysfunction in a male around 40 years, then progressive MS becomes more likely. So you can, by and large, in a given case, get around the idea whether this is RRMS or whether this is primary progressive MS. But you need to observe for 3 months, 6 months, 1 year to really know what is happening. Now, the next part of the question is, are the treatment options any different? Now, for that, we have to first of all know, is the mechanism of the disease the same? What we understand in MS is that it's an immunological disease. Some of body's own cells start going against it. And therefore, when the inflammation is more, it destroys the myelin, and therefore a neurological dysfunction comes like optic neuritis, cerebral ataxia, spinal cord dysfunction, double vision, things like that. Then the inflammation settles down. It remains settled for a while and comes back again. If you look at the pathophysiology of primary progressive MS, meaning patients who start slowly and go on having a problem, in them, the process of degeneration is also going on simultaneously with the inflammation, which comes in RRMS later on. So they're pathophysiologically a little different. And obviously, the treatments will therefore differ. The big treatments for MS are all tackling the immunological system. So for RRMS, you modulate the immune system by various mechanisms, like you will give methylprednisolone, you will do plasma exchange, you will give IVIG, you will use a drug like azathioprine, mycophenolate, rituximab, what have you. So that's that set. Interferons, Tecfidera, there's so many of them now. On the other hand, for primary progressive MS, there are very, very limited options, and it's a progressive disease. Some of the monoclonal antibodies that have newly come in have been approved for primary progressive MS, but overall, the number of drugs available for that form of disease are very few. Now, RRMS usually changes into a SPMS, secondary progressive MS, where a first attack comes, patient becomes completely normal. Time goes by, second attack comes, patient again becomes normal. Third attack, fourth attack, fifth attack, they don't become completely normal. They leave behind a little bit of residue. And that residual damage goes on increasing, which we call secondary progressive MS. So RRMS can change into secondarily progressive MS. As far as the primary progressive MS is concerned, it is already progressive.
Correct.
So there's no question of a secondary progress there. It's progressive from the word go. Now, the question that Dr. Bhatkande asked is a very, very interesting question. That you've got somebody who has got PPMS, meaning from the word go, he's slowly gaining disability and his disease is slowly progressing. On top of it, can exacerbation remissions come? So the answer is it does happen infrequently. First of all, primary progressive MS is rare. And within that rare or the small group of patients who have the primary progressive MS, some of them, meaning fewer still, will get attacks on the primary progressive course of the disease. So there are really four forms of the disease: RRMS, SPMS, PPMS, and secondarily relapsing remitting MS, which is the least common group, but it has been documented.
Right, sir.
So that's the general profile of the
Right,
patients.
sir. Thank you so much. In fact, the next two slides were actually probably fitting in one of these categories.
Yes.
Here we have a patient who is actually from Gurgaon, and he was told that he has a progressive MS, and then he had an episode where his right leg was affected. He was given treatment as you would in any relapse case, and then he was also asked to take a disease. I mean, your rituximab. Now the thing is that his question really is very relevant to today, because we know Delhi, Mumbai have got the highest number of cases of COVID. So he's just worried that if he was to take steroids or any of the disease-modifying drugs, would that make him more vulnerable to catching the community, the community spread of COVID? And
Right.
is there anything that could be safe to be taken to halt or to mitigate the disease progress?
Right. Right. Again, a very good question. And to put it in perspective, I think at this point in time, as we stand today, we do not have a vaccine for the COVID as yet. And we really do not have any medication that prevents COVID from happening. So we do not have any preventive steps. The only thing one could do is to take adequate rest, pump oneself good of vitamins, vitamin B complex, vitamin C, and things like that, and keep a positive frame of mind. All these three things sort of improve the immunity. Now, the question is that you are having MS and therefore you're being treated with an immune modulator. There is no answer to this. If your MS is active, you need to take those drugs, you need to take those drugs. So your options will be mainly preventive in terms of COVID, like making sure that there is a mask, making sure that you are social distancing, making sure that at your home people do not come. So the advice is to continue your MS drugs and take maximum care that you can for COVID. But there is no medication that you can take to avoid COVID. None of us can. Similarly, the MS person also cannot. But
Yes.
there's no need to get afraid. God is there.
Yes, absolutely. I totally believe that. So our next question is something very similar. A patient from Ahmednagar had undergone a whole lot of treatments. Now he's stabilized, but he has ataxia and spasticity, which is giving rise to frequent falls. So he wants to know that though I'm taking the medication prescribed, though I'm doing regular physiotherapy, I mean, my symptoms seem to be worsening. So, and he wants to, seen at least about a 20% improvement.
Right.
So what do you say to that?
Right. You see, people often ask this question. I'm doing everything that you all tell me to do. Still, things are getting worse. Why is that so? Now, the real answer to that is that if you were not doing all these things, you would be worse. So, because you're taking your medicines, you're taking your rest, you're making sure that your immunity is all right, you're taking everything, that you are at a point where you are. Otherwise, the disease would have damaged you more. So, where you are is a result of following all the good treatments that are known to help people. Now, will I improve? I think every patient should believe that he or she will improve. Every doctor should believe that his or her patients will improve. They must make every effort for that to happen. Now, whether that will happen or not, then is to be left to the forces that decide it. And those forces are neither the doctor nor the patient. So, if you ask a question like that, is there a chance? I think there is always a chance. There is always a chance of getting better. You have to believe it. Your doctor has to believe it. You have to work towards it. Whether it's going to happen or not is not in your hands. So this is where the teaching of Gita comes in. Karmanyevadika raste mam phaleshu kadachana. What you have to do, you have to do. What I have to do, I have to do. Then leave it to the Almighty. I have seen improvement coming at any stage of the illness. After 5 years, 10 years, 15 years, 20 years. So there's no need to be dejected. Keep thinking positive. As far as spasticity and ataxia are concerned, the symptomatic treatments like amantadine, lyofen, tizanidine, they help. So you go back to your neurologist and ask him, for my ataxia and spasticity, can you give me something, or are you already giving something? And have a discussion with him whether any drugs can be used beyond what's being used. And there are some patients who do well on some drugs when they don't do well on some other drugs. So there's always a scope to change. Yeah, I think that's the answer. Have we lost the communication? Hello?
Yes, sir. Ma'am is just connecting.
Yeah,
Okay.
I'm so sorry.
Yeah.
I believe, sir, there is a poor connection at Dr. Rekha's end.
Okay. Yeah.
We'll just try to get her back.
Yeah. I think she's
Hello?
there. Yeah.
Yeah.
She's
Rekha,
there,
ma'am,
right?
are you able to hear us?
Yeah. I can hear you. Yeah.
Ma'am got disconnected, I believe.
happened to me. I'm sorry about
So give us a moment. We are trying to get Dr.
Sure,
Rekha back
sure,
on the call.
sure, sure.
So my team is getting connected with Dr. Rekha over phone and trying to sort the issues out.
Can I start answering this question? Because next question has come on the thing. Or wait.
Sir, I believe you can proceed from where we had the last discussion. Till the time we'll get Dr. Rekha on.
Yeah. So get the next question on, please. No, I think the one. No, go back and go back and go back. Yeah. Now go ahead. Yeah. I think she seems to have arranged them in a certain manner. So let her come.
Yeah, I'll just give you an update, sir. Just give me a moment, sir.
Yeah.
Hello. Sir, I just had a word with my colleague. He said that ma'am has asked us to proceed. She'll be joining in the meantime.
Okay. Right. So let's take this question that is in front of us now. Why is early treatment important? Have MS genes been discovered? Do a healthy diet, exercise, management, or other medical conditions impact a person's MS progression and lifespan? And is it true that smoking can impact the risk of getting MS as well as the progression of MS? Yeah. So I think all four sections of the question are important. So let's take the first one. Why is early treatment important? See, it goes back to the understanding of the disease mechanism. I told you in the beginning that MS is an immunological disease. So when this process of an immunological disease starts, some antibodies are created, some cells start working against body's parts, which in this case is myelin, and then they start nibbling at the myelin and they produce inflammation of the myelin, and then the myelin starts disintegrating. The early phase of the disease in MS is called as the inflammatory phase, where all these inflammatory responses are mounting. Inflammatory cytokines and other substances are accumulating, cells are gathering, and then they are doing their damage. Once this stage goes on, the inflammatory stage starts merging into what we call a degenerative stage, where the myelin has already been damaged. Because the myelin has been damaged, the axons get damaged. And because the myelin and axons are damaged, a certain progressive degeneration sets in the myelin and the axon. So the early phases of the disease are inflammatory, and later phases of the disease are degenerative. Once you understand that, it is very clear to realize, or very easy to realize, that therefore you have to tackle the illness at the stage of the inflammatory disease. When the inflammation is coming on, you have to treat it so that you prevent further damage. You hopefully prevent the second sort of degenerative stage to come on. So the early treatment is important. Therefore, people, even when they have a little disability, they shouldn't wait. They should go to their doctor. They should have the treatment options thrashed out with the doctor, and preferably start treatment when medically it is recommended. A lot of people in India wait for one reason or the other. Sometimes the cost, sometimes the fear of the side effects, sometimes the general worries about the allopathic medications. And in that time, if the inflammatory phase goes away, then you're straight looking at the SPMS. So I think it is very important that you discuss with your doctor and start your treatment early. Have genes been discovered? Yes and no. For every illness, every human illness, there is an environmental part and there is a genetic part. So in MS also, there is a role of the environment and there is a role of the genes. Now we have understood that certain HLA types, HLAs are human histocompatibility antigens. Some HLA types are more likely to be associated with MS. So the answer to the question, have genes been discovered? There is some idea as to which genotype is a little more susceptible to the onslaught of MS. But unless such an individual who is considered to be susceptible genetically goes into environment that pushes him into the disease may not manifest. So it's not only the bad gene, not only the bad environment, it's a combination of the two. And we are understanding human genetics more and more. And in MS also, we are understanding it more. Currently, we know about the HLAs, and we will know more about genes in MS. A healthy diet, exercise, management of other medical conditions will generally impact MS favorably, and that must be done. Now, like I told you, people always ask me, I never took alcohol, I never smoked, I always exercise, still why am I getting it? The answer, as I told you some time ago, is if you hadn't done it, the disease would have been worse. So all these things you have to do to give yourself your best chance. Now, lastly, question: is it true that
Yeah, I'm coming
smoking can
on my
impact the
phone.
risk of getting MS? Yeah. Now, can smoking have an impact on MS? Now, see, impact is a broad word. Some things have a large impact, like high blood pressure has a large impact on heart attack. Diabetes has a large impact on heart attack. Similarly, smoking doesn't have that sort of a large impact of MS. If at all there is an impact, it's a very minuscule impact which has been shown in um, statistics. Now, statistics is a very tricky thing. You can prove or disprove smaller things as you want, depending on which model you use. So, statistically, it has been shown that smoking, people who get MS, the chances are higher that they would be smokers. So, that's an association. Whether that association has any causative mechanism, we do not know, but we do not really think so. So when somebody is smoking and he asks, should I stop smoking for the sake of my MS? The answer is no, but you should stop smoking anyway, because it will do worse thing than MS.
Yeah. So can you hear me?
Yes, you're absolutely
Oh,
fine.
wonderful.
Yeah.
I've come on from my phone.
Yes.
Sir, I actually just wanted to ask you, this
Yes.
radiologically isolated syndrome,
Yes.
and then
Yes.
the clinically isolated syndrome. I mean, this is
Yes.
where actually the early treatment is required,
Yes.
and so could you
Yes.
just tell all of us a little about that, please?
Yes. Absolutely. See, as the field of MS developed, all doctors used to say that if you have two attacks separated in time and you do not have any other explanation for it, it will be MS. Like you have an optic neuritis, which becomes better. 1 or 2 years go by, then you have an episode of spinal cord dysfunction, which becomes better. You say, okay, this individual has had two attacks and in different parts of the nervous system. So dissemination in time and space, and it is MS. Because at that point in time, to diagnose MS, we had only clinical parameters. Then came the MRI, and the MRI became better and better and better. So when you started doing the MRI the first time an attack came, you realize that some MRI characteristics are making you reasonably sure that this person will get a second attack. So the criteria for the diagnosis from the clinically definite MS became MRI supported MS. And in the coming years, the MRI took up so well and the MRI capabilities increased so well that MRI became an inseparable part of the diagnosis. So now when a patient gets a first attack and the MRI shows certain changes, you will think to yourself, okay, this patient doesn't have yet two attacks. So this is a CIS, or clinically isolated syndrome. But this MRI tells me that if I keep waiting, second attack will come. So that's how MRI actually has helped us understand the MS process much earlier. And therefore now we pick up the MS or make a diagnosis of MS with one attack and the MRI showing suggestive changes, the lab supported MS. Now
Right,
go a
sir.
little one step further and say, okay, you went into MRI for whatever your reasons, maybe say headache, which your doctor thought was a migraine headache. But the MRI shows multiple sclerosis picture. So what are you going to do? That is the radiologically isolated syndrome. Now for the clinically isolated syndrome, most people will now start treatment if the MRI is suggested. For the radiologically isolated syndrome, there is still a little concern whether you should start or not, because everything that you see on the MRI doesn't reflect into the patients. But more and more people are leaning towards treating the the RIS also. So that's how the field has moved towards early treatment, and MR has been a big step there. Yeah.
Thank you, sir. Uh, Sir, one of our patients has been having palpitations, and she feels she misses her heartbeat, and especially since the last few months. And actually, she's suffered from COVID and has recovered from it. But she's very anxious, extremely active young MSP. So, if you could just guide her, please.
Yeah. So basically, like I said in the beginning, the actual treatment and the actual workup you will have to go back and do with your doctor. But some comments I can make in general. One is that multiple sclerosis does not affect your heart. So there is no reason for the heart to skip a beat and for you to get palpitations on account of the MS. So there must be something else happening. That something else is so often anxiety. And I must congratulate you that you have MS, you have COVID, and you have fought both, and you are already well. So obviously you are a fighter, but
Yes,
you're fighting two things. You're fighting two things.
no, no,
So
she's
not unusual to get palpitations. So I think the palpitations need to be investigated on its own accord. Is there a thyroid problem? Is it just anxiety? Is the blood pressure going up and down? And 99% you will find a reason in something other than MS. It won't be MS.
right, sir. Thank you, sir. Um, uh, a lot of MSPs have been talking about sleep disturbance, and they wanted to know whether it was vitamin D level being down, or whether because of their therapy, or is it just that they're so fatigued during the day that they nap, and that is why they're nocturnal, their night sleep is disturbed. So, is there any comment you can make on this?
Yeah. See, first comment is human sleep is very, very complicated. We first of all we don't know why we sleep. So our our knowledge about sleep is very limited. But sleep links a lot with the mind, anxiety, lack of physical exercise. So if you're not taking enough physical exercise due to whatever reasons, you should start taking it. And people always say that, look, I have got this MS disability or stroke disability, whatever, I can't exercise. But whichever limbs are good, you can exercise them. If you can walk, you should walk. If the hands are okay, you must exercise. So I think physical exercise and preventing anxiety. Now, I do not think that the disease modifying therapies directly have an impact, a big impact on sleep. Some patients may get, but that's uncommon. And vitamin D nowadays is associated with everything. So I don't think it's specific. That's another, you see, statistical thing. If you take two common things and try and associate them, you will find the association, no, because they are both very common.
Yeah, the Venn
So low
diagram.
vitamin D is very common.
Yeah, the Venn diagram.
So
There's always an
exactly,
overlap. Yeah.
exactly. So that's a statistical truth that you read in the papers about vitamin D. If it's low, you should replace it. If your sleep improves, very good.
True, sir. Thank you, sir. The other is about the question here really is, does stem cell therapy, is it useful in multiple sclerosis? And this boy, he's actually from out of Mumbai, and and he's been really, working, struggling to keep his quality of life going, and
right. Now, see, every neurological seminar, questions on stem cell come, and I think we must go a little into the depth of this. Now, what is a stem cell? Stem cell is one of the precursor cells that you see in embryonal life or that you see in blood cells, which has a capacity to convert itself into another cell. So it's the progenitor cell, or it's a cell which has a capacity to change into another cell of the body, which is a unbelievable potential, what is called totipotent in medical words, able to change into anything. So you got these cells which have this capacity to change so incredible. So everybody has been trying to see, can we tap this, and can we make the cells change into myelin? Can we make the cells change into something? And the current state is that we have not developed mechanisms good enough to convert those cells into what we want at our will, and then put them there.
Right.
See, for example, in muscular dystrophy, I was working with a patient organization, just like this MSSI. There is a very active patients group in muscular dystrophy, and they generated some resources, and we did some stem cell experiments, scientific experiments, where from the abdominal fat, cells taken out from the abdominal fat, what are called mesenchymal cells, we could change them into muscle cells in a petri dish. And this has been done in Bombay and replicated in Hyderabad. So it's not hearsay. We can do it. You can convert a stem cell into a muscle cell. It takes 44 days and it takes 3 passages. But they have to be very nicely organized for those 44 days. The problem is, okay, in a petri dish, you created muscle cells. What do you do with them? How do you put them in the body? Whatever you put in the body will consider them as foreign and kill them. So stem cell experiments, so stem cell as a philosophy is very, very powerful. But bringing that philosophy in practice as yet is not possible. You cannot change the cells at your will. You cannot put the changed cells into the body where you want them. If you put them, body kills them, body doesn't make them last. But after having said all this is a very powerful concept that there are cells which can convert. And sooner or later, when we will get the idea of how to do this, we will be able to use stem cells wonderfully. It has not happened. In 2020, that has not happened. And therefore, the problem that all these centers are there, they say, you come into the hospital, we'll take your own cells from the blood, and tomorrow morning we will put in those cells, and then you will become better, which is all nonsense.
Right.
It happens in our country, it happens in Ukraine, it happens on a boat from Ireland to England.
Yes.
It's all sham.
Yeah.
As it stands today. Now,
right.
When I'm saying it's a sham, I'm not maligning the concept. The concept of stem cell is very powerful. But at the moment, it is hypothetical. So presently, if someone tells you, can I take stem cell therapy? The answer in 2020 is no. But there is always a possibility that in 2025, there may be a nice program which you can say, you can go and take this and this will do this. So it's something that has potential but hasn't happened.
Right, sir. Thank you, sir.
Also, if I may say, the Indian Academy of Neurology constituted a committee when I was president of the academy in 2018. And we went into evidence of stem cell therapy in all neurological diseases, which included MS. And at this point in time, the committee came up saying that there is not a single disease where the Indian Academy should endorse. And that has subsequently been published. So that's where we are. Yeah.
Thank you, sir. The next question is, of course, in Marathi. So if you could answer in Marathi, sir, that would be great.
Yes.
The thing is that she gets this severe pain on the left side of her body, and it's quite debilitating. And all her investigations are normal. She's on painkillers. She's taking immune modulating drug about as around 100 milligrams a day. So is there anything that you could, just advise her about?
Right. See, multiple sclerosis मध्ये वेदना होणं हे होऊ शकतं. ते वेदना साधारणपणे इलेक्ट्रिकच्या शॉक सारख्या, मुंग्या आल्यासारख्या वगैरे अशा प्रकारच्या असतात. आणि शरीराच्या संबंध एका बाजूला, कमरेच्या खाली दोन्ही पायाला, एका हाताला अशा भागांमध्ये ते येऊ शकतात. त्यामुळे पहिल्यांदा डॉक्टरना तुमच्या हे विचारायला हवं तुम्ही की हा MS चा भाग वाटतो त्यांना का MS पेक्षा काही वेगळं वाटतं. जर तो त्यांना MS चा भाग वाटत असेल तर त्याच्यासाठी गॅबापेंटिन, डुलॉक्सिटिन या प्रकारची ॲलोपॅथिक औषधं देता येतात. जर तो MS चा भाग त्यांना वाटत नसेल तर त्यांना त्याच्यासाठी टेस्टिंग करून दुसरं काय आहे ते पाहावं लागेल. कारण स्पॉन्डिलोसिसने पण तसं होतं, आर्थरायटिसनी होतं, अनेक कारणांनी होऊ शकतं. त्यामुळे पहिल्यांदा डॉक्टरांच्याकडे तुमच्या जाऊन त्याचं मूळ कारण काय आहे ते मिळतंय का ते शोधलं पाहिजे. त्याच्याप्रमाणे मग ट्रीटमेंट गाईडलाईन्स तुम्हाला अवेलेबल होतील.
थँक्यू सर. Sir, this MSP, actually she has not asked a question. She is very, very upset with the entire medical fraternity because one of the symptoms that she faces, she's got paraparesis. Okay, she has all the other things, and she's okay with it. She's learned to adjust with that. But she gets perspiration. She gets perspiration and of the upper body. She's paraparetic, remember that. And she gets perspiration of the upper body so much so that the minute she goes out, it's almost like she gets dehydrated and faints. And so people around her are very worried. And so she does not, socialize. So she says, is this a symptom of MS? And if so, what would you recommend as a treatment?
Right. See, basically, the spinal cord also controls the sweating. So when MS affects the spinal cord, it can also change the sweating. In that some people can sweat more, some others can sweat less, things like that. So at the first go, I think that it could be a symptom of MS. But as usual, you have to ask your doctor who has examined you whether it's a part or it's something else. Now, for a long time, no medicines were available for this. But of late, a medicine called glycopyrrolate is available, which can help the symptoms of excessive sweating. And there are other diseases also where sweating can be excessive, where in some patients we have found it very successful. So you can take the name down, glycopyrrolate, go back to your doctor, ask him, ask two questions. One, is this part of MS or no, or should anything else be investigated? And two, can glycopyrrolate be used? But strictly, that will have to be given by your doctor.
Yeah. Right, sir. Thank you, sir. Very similar is that, people are very worried about heat-related symptoms, and now October heat is coming up. So, and what should we be doing to ease these effects of the heat? But the same MSP has asked that in the winter, cold weather seems to exaggerate or aggravate his spasticity. So how do you deal with,
See, basically, our nerves are like electric wires. And the conduction of the nerves depends on 100 different factors, heat being one of them, the temperature being one of them. So the same nerves will conduct differently at different temperatures. So both these phenomena are very well known. That when the temperature increases, patients feel not so good, what has been called the Utov's phenomenon. Like they go and take a hot water bath and the vision becomes low. And then they come out and their vision becomes better. That's how this was initially identified, the Utov's phenomenon. And cold weather does increase the stiffness. Now, because MS affects the myelin, it affects the nerve conduction more, and therefore both these symptoms are part of that. Are they temporary? Yes, they are temporary. Once the temperature comes down, the symptom will become better. Classically, symptoms come after hot water bath. As soon as the body cools down, they become better. Yeah.
Thank you, sir.
So one has to avoid getting cold. Getting out in the cold weather, and I think use air conditioners and things like that.
Yeah. Thank you, sir. Here, the thing is that the patient has had MS since 2016, and unfortunately also had a fracture, and that leg is now very stiff and weak. And the thing is that the MRI has not shown any new lesions, but the patient has been on disease-modifying treatment. And so she just wants to know, is there anything other than, MS treatment that could help her out?
Well, I don't think this question can really be answered. But again, general comments that whenever a patient of MS gets bedbound for whatever reasons, like here a fracture, the MS symptoms seem to increase, and lack of physiotherapy adds to it. So if something has to be done, it is going back to a good physiotherapy program and making yourself active. So that really helps most of the people. Now, the second question is, with the past history of MS, is it necessary for me to take medication for a relapse? How long to give medicines and which medicine is best, your doctor will be able to tell you. But earlier, you will have immunotherapy, and later on, you will have symptomatic therapy. Yeah.
Thank you, sir. Here the patient is again very worried about corona, but here it's about the medication given as in the corona period, and that is your HCQ and your Fabiflu and azithromycin and all the rest that have now been added to the list. And how does it really differ in a person with MS and without MS?
See, it's a new virus. There is no guru in this. Nobody knows how these things will interact. And for every patient, the doctor has to go by using minimum medicines for corona if the person has MS. So it's not that we have been tackling corona for 100 years to answer these questions. We don't know. I'm quite plain about it. We don't know. And knowing that we don't know is the most important step, because it tells us that to use minimum drugs for corona in a patient of MS. It will entirely go by case, what is happening to the patient. Yeah. There are no guidelines on a new disease.
Sir, the social medias have been very active, even more active than the medical fraternity, I feel, about how to treat corona. And vitamin C is a big thing. It's a new kid on the block, and everybody tells you to take sour things so that you get more vitamin C, and that's better for corona. So, does that in any way affect MS? Taking sour?
Nobody knows, because these situations have not come again and again for anyone to study them. I don't think there is any existent literature on new things. And if someone says there is, I think you read it carefully. Right. So I think here we have to entirely go by common sense.
True.
I don't think there is any written literature on this.
Sir, could vertigo be a part of MS, or is it
absolutely? Absolutely, it can very much be a part of MS, because when it affects the 8th nerve segments, it can give you a very bad vertigo. So just like there can be a visual problem, a spinal cord problem, an ataxia problem, a speech problem, a double vision problem, vertigo can be a manifestation. Absolutely.
Right.
But common vertigo vertigo again is so common, and there are so many causes.
Yes.
It could be any other as well. Yeah.
So year, due to the year, should be first ruled out, even in an MS patient, right?
Yeah, absolutely. The common things are common. Yeah.
Right, sir. Here, the patient has blurred vision, optic neuritis, and that has never really recovered. She never really recovered from that. The MRI recently done actually shows no evidence of MRI lesions. So, I mean, does that happen very often? That you have MS, you have recorded MRI lesions in the past, and now the latest MRI doesn't show any evidence of MS.
Hey, but does this patient have previously MRI lesions or never shown any MRI?
No,
lesions?
I think it's from what I can see, it's only optic neuritis.
That's right. Now see, there are 2 or 3 other diseases which are close to multiple sclerosis within the group of demyelinating diseases of the nervous system, particularly neuromyelitis optica, and another one called MOG antibody, which have a brunt on the optic nerves. So first question in this case is this MS or not? And if it is not MS, then is it neuromyelitis optica? Is it a MOG antibody disease, or it is just plain viral optic neuritis?
Only thing that the patient does complain of urinary incontinence.
Right. Then there is something more going on.
Yeah.
Which again, NMO antibody NMO can do that. So MS versus the non-MS type of demyelinations, the so-called opticospinal in the past.
Right.
So a full review of what is the diagnosis.
Right.
That must be done. And the fact that the vision did not improve very well is more like neuromyelitis optica than MS. In MS, it usually recovers well.
Yes. Thank you, sir. Here, the patient has all the major problems and is okay. I mean, these are the major problems. We've all been reiterating about that. She just is wanting to know, how do I improve my quality of life?
So the answer to this is partly philosophical and partly scientific. Everyone who has an illness must learn to realize and appreciate that the damage does not rule their lives. It exists, but it doesn't rule their lives. Once you realize that, you are free from the disability. It is only when you will keep thinking about the disability, oh, I've got this problem, oh, I've got this problem, oh, I've got this problem, your quality of life will go down. In majority of the people whom I consult, there are two factors for quality of life. One is the disease itself. The second is the mind, the way the mind works towards what has happened. So what has happened by way of disease, whatever treatments are available, you should take. But what the mind is doing, that only you have to avoid. So to improve your quality of life, what you need to do is to take the best possible medicines from your doctor, and in your mind, believe that the disability does not rule your life. If you can do that, your quality of life will improve in that one instant.
Right, sir. Thank you, sir. Here, there are a couple of, one-line questions, and so they're in different languages. In Marathi, आता MS आहे तर पुढे काय म्हणजे what should they look towards? What are the things that could happen to them?
Okay.
MS मध्ये पुढे काय problems होऊ शकतात?
Okay. Right. This is again, if I'm leaning a little too much to philosophy, but I think all science meets philosophy. See, if there is a glass half filled with water, you can also say that the glass is half empty, and you can also say that the glass is half full. So what wrong can happen? Why are you seeing in future?
Yes, true.
Why are you not seeing what good can happen?
True.
See, new medicines may come, a cure may come, you may start again walking very well. Why are you looking at the half empty glass?
True.
Yeah. So there is a story, if I can tell in a minute.
Yeah. Sure.
There was a room full of horse dung.
Okay.
And two people were put in the room. So one fellow says, oh, what a terrible smell, and where have I come, and why life is treating me like this. And the other fellow starts digging. So the fellow is saying, as such, there is such a terrible smell. Why are you digging? He says, if there's so much horse dung, there have to be horses somewhere.
Okay. That's wonderful. Yeah.
So I think you have to look at the good things. What will happen in future? A good medicine may come. A cure may come. Look at it that way.
Yeah. So the next is Asan Hindi. I know this MSP lives away from the city, so she finds it very difficult to connect with a neurologist. So she just wants to know if symptoms, that means if there is a relapse, is there any way she can deal with it herself?
Right. Now see, there are 2-3 things here. The medical system in India is quite amorphous. Primary care, secondary care, tertiary care has not been so well defined. It doesn't mean that the primary care physician is not capable of treating MS under the guidance of the neurologist. So the best thing that she can do is to go to her family doctor and say, can you please speak to my neurologist and discuss with him, what can you do if XYZ happens? That is the easiest solution for her problem. And secondly, I think now with this, in the COVID times, one very good thing has happened, that the whole country has taken to the virtual, like what we're doing now. So I think even reaching the neurologist is not going to be that difficult now.
Yeah. So of course, everybody wants to know, will remyelination ever happen in MS? And of course, there are a couple of questions, sir, about walking normally. And perhaps this orthotic, implements and equipment that is now there, perhaps that could help. Does it help MS patients too?
Yes. See, as far as remyelination is concerned, remyelination is continuously happening in the body. Body is a self-repairing machine, but the speed of remyelination is not enough in patients of MS. So whether remyelination happens, it happens regularly. That's the way body is. The only question is that the demyelination has more speed because of the disease. Secondly, I think in the last few years, physics has really gone ahead with
Yes.
leaps and bounds. Absolutely amazing. So what the orthotics people now can do, unbelievable. As far as the gait is concerned, they can analyze the gait so beautifully and have robotics attached to the human body. And I think pretty soon you will regularly have machines which will make you walk, moving your own legs in the way they should move. So I think again in that area, I'm very optimistic. There are some Japanese demonstrations that I saw a few weeks ago where a completely computer assisted program was working on the orders given by the brain cells
Wow.
to make the person walk, and the patient was paraplegic. I
Wonderful.
think it's physics wise, it's absolutely exciting time.
Right.
Yeah.
Thank you, sir. Here the thing is that we have this very, he's extremely enthusiastic MSP, but he feels that his thighs are, they pain and they feel very heavy. That makes him, walking quite difficult. He also gets all these paresthesia, So he wants to know how does he deal with this?
Yeah. I think two things. One is to go to the neurologist and ask him whether there is spasticity, whether anything should be given to reduce the spasticity. For the tingling numbness, whether any medicines like gabapentin and duloxetine should be used. So those two things the neurologist can do for him if they're already not done. And secondly, go to a senior physiotherapist.
Yes.
Let the senior physiotherapist analyze what are the walking difficulties. And like we discussed a minute ago, there are now these computer assisted programs that tell you what's wrong with your walking.
True.
And
True,
it helps a lot. Yeah.
Absolutely. Thank you, sir. Here, of course, it's about tremors. And is that also a part of MS? And can exercise actually be, can that help? And his second question is that how often does one do an MRI or needs to do an MRI?
Right. Now, tremor is a part of MS, and there are various types of tremors that you see in MS. So again, your doctor will have to analyze what tremor it is, because tremors can be reduced by some medicines like beta blockers, amantadine, and there are some selected patients in whom you can also take a surgical approach by lesioning in the brain when the tremors are very, very dominant. So tremors have medical approaches, surgical approaches, but the case will have to be very, very well selected by your neurologist. Yeah. How often to do the MRI? It's case based. You are trying to see the activity of the disease. So depending on how you are going, your doctor will have to tailor specifically for you when the next MRI is due. So there is no set schedule for that.
Right. Thank you, sir. Here, the patient was on interferon. Then the patient was shifted to PEG interferon. Interferon, all the side effects of interferon have, almost tripled or trebled, I would say, with PEG interferon. So, I mean, that's all. But now the patient is very, very, worried about taking PEG interferon. So, what would your advice be? I mean, it's all about side effects more than that the therapy and how the therapy is helping. It's more about side effects.
Yeah. See, one of the problems is that people are worried about the side effects, but wherever there are effects, there will be side effects. So one has to try and minimize that in such a manner that the effects are more than the side effects. I think as far as efficiency is concerned, Plegridy is just like Evonex. It's, except for the formulation, the medication is the same. So efficiency is the same. If the side effect profile for a particular person is not good, then he or she should go back to Evonex if it was helping better.
Right, sir.
or ask the neurologist whether tablets can be given.
Right, sir. Thank you. Here, this is one of our patients who actually comes from, her siblings have got MS too, and so it's very difficult for the mother to be looking after these 2 or 3 girls who've got MS. And one of them, she says that she's so weak, muscular weakness, that she literally has to drag herself everywhere, and her legs and her back are very stiff. So she's on baclofen, 5 milligrams 3 times a day, but that doesn't seem to be working. And she, they're even financially, they're very constrained. So, we've been trying to help them through MSSI.
There are other spasticity medicines like tizanidine or others. So they could be tried, clonazepam. And just like tremors, there is a medical therapy for spasticity, there is a surgical therapy for spasticity. So even rhizotomy and procedures like that are also being done. And a lot of these are also done in Grant Medical College and KEM
Right,
Hospital. So I think they can definitely help there.
Yeah.
These departments are doing great work.
Right. We will ask her to hook up with
to go to either JJ or KEM or Nair.
Right.
Dr. Chakor is there, very good.
Yeah, we'll do that. So a very, very important question is about pregnancy. And added to pregnancy in an MSP is also this whole uncertainty of COVID that is happening now. What is your take on that?
I think the COVID related questions, there are no scientific answers with me. And this looks like a hypothetical question for me. If you want to get pregnant, go ahead and get it. Don't worry about what is happening.
Actually, this patient is newlywed, and the pressures, the social pressures, and she wants to have a baby, but she's very worried. What happens about getting an MRI done, taking treatment,
See, I think worry is not going to take her anywhere. She has to make up her mind whether she wants to get pregnant and have a child, then takes the risk and goes ahead. There is no other way. This sort of question is just a to and fro discussion.
I know. And it's so individual also, sir.
Absolutely.
Thank you.
How does one see, even in a normal pregnancy, how does one know what's expected? We don't know.
No, we don't know.
So I think we don't know. We only presume we know.
Yes.
And we worry.
And we worry a lot, sir.
Yeah, quite unnecessary.
Right, sir. So, so there's a question that was asked. In fact, it was asked just this morning on WhatsApp. Yes. Is there any role for plasmapheresis? I mean, plasma therapy, as they call it. Is there any role for that in MS?
Yeah. See, when an MS attack is very severe and it doesn't respond to solumetrol, plasmapheresis is one modality that you can employ there as a rescue therapy or an intravenous immunoglobulin. So plasma exchange and intravenous immunoglobulins are called rescue therapies in people who are not responding to solumetrol during an acute attack. So it's a treatment for acute attack. It doesn't help the chronic cases.
Right, sir. This MSP also has a foot drop, but then we've already explained to him what rehabilitation and possible use of orthotic equipment may help him. Jayesh, if you're listening in, are there any questions that have come in from the audience themselves on the chat? Because then those can be asked, perhaps. Because we've got time on our hands, and I'm out of questions that have been sent to me. So, is there anything else?
Yes, ma'am. So you have to excuse me, Mr. Jayesh.
Okay, I'm having a look at the chat. Yes, I'm having a look at the chat. Okay. Yeah. So these, these side effects of all these drugs, the newer drugs, I mean, that's what's really bothering people, that, they have so many side effects and, fingolimod and, so many side effects. So how does one really deal with that, sir?
Yeah. You see, basically, I think we have to realize that in the MS area, the current thinking has been moving to tackle the disease at the early time with the best weapon that you have. So, what is called NADA, or nil activity of the disease, is the current concept. So, to do that, you are designing more and more powerful medications to be used earlier and earlier. Now, all the medicines are like double-edged sword. When they are going to be more potent and they have a potential of helping you more, they will invariably, by virtue of being more potent, have adverse effects. So you cannot expect that there will be a medicine which will only give you good effect and will not give you a bad effect. So you have to first of all decide, you and your doctor together, what is the strength of MS in me? How bad has it come? What sort of medicine should I take? Then choose the medicine. Once you choose the medicine for its potency, you have to accept the side effects. If for some reason the side effects become unacceptable to you, then you have to look for an alternative. But that's the process of medicine. And that's where you require a senior neurologist to help you. And that's where you also need a patient who understands that side effects will be there. And you have to identify them early and you have to guide through the side effects. Generally, they are acceptable. I have hardly had patients who need to be shifted from one to the other because they just can't take the drug. But they are there. You can't negate them. Yeah.
So can you just explain a little about EDSS?
Yeah. It's a technical scale which basically was designed for research in multiple sclerosis because it takes into account some functions of the body and gives you a score. So for every dysfunction, it will give you a score. For every good function, it will give you a score, like the eyes, the balance, and things like that. So ultimately, you come up with a total score. And when you started a medicine, after 3 months, if you do the total score, then again after 6 months. So it is an objective tool to measure the disability of MS, which is used by people to track a case. Is the medicine that I have given helping the patient or not? Having said that, in India, the workload on neurologists is so high that doing the EDSS in a clinic is very difficult. But in the research settings where they have more assistants and they are tracking the diseases, EDSS is a good measure and a measure that is used worldwide to objectively track how the disease is doing.
So we have technicians in every field. Why can't we have neurotechnicians? Why can't we actually, have a capacity building where all this can actually be done either by nurses or technicians, and the
I think
report be given to you?
You have said a very, very good thing. I think if through the MSSI an infrastructure like that can be created, it will really help because every neurologist wants to see the ADSS, but he doesn't have that much time with him to do it. So I think you have put forth a fantastic point. And if even on some patients or some group of patients, if it can be executed, nothing like it. It's not difficult to learn. The ADSS is a very simple scale. A volunteer or a nurse can definitely do it.
No,
Very
because,
good point.
because sir, now there is this whole, movement of the disability certificate,
Yes.
and
Yes.
that is where, MS patients are really losing out on, because the
Yes.
current rules of disability certificate is 40% visibility of the disability. I mean, it just goes against the entire MS, thing.
The way the
So,
disease is. Yeah.
So I feel that maybe something like this, where we score the patient with
Fantastic.
disability.
If the MSSI, with the help of medical personnel, can provide EDSS scores
Yes,
when the patient goes for a certificate,
yes,
then it becomes that much easier for the medical officer who is in charge of giving the certificate. He may not know what is EDSS.
right, right.
Perfect. Perfect.
So one
Very,
more
very
question.
good.
Yeah,
Yes.
one more. I would say it's a plea. I
Yeah.
know the neurologists. I believe we only have 13,000 neurologists in the whole of our country.
2000.
Oh, 2,000, 1,300.
2000.
Sorry, you added
Yeah.
700 more.
Now
1,300.
2000. Yeah.
Okay, 2,000 neurologists. And I
Yes.
know the workload is tremendous. But,
Yes.
sir, is it possible for a neurologist to be on the panel of the disability,
He-
functionaries?
They must be. There is
Why
no
don't we
no.
have one
Yeah.
then? Why don't we have?
I think for this the way will be to go to the Grant Medical College superintendent and say that these are the problems of MS. So when you're giving a disability board, that they have disability boards for everything,
Yes.
you please include a neurologist in the disability board of MS. And once JJ will do it, whole Maharashtra will do it. Once one state does it, then everybody does it.
So
The way
why
is through JJ.
so why can't the Neurology Society of India proactively do this?
One could sort of look at that approach. Like there are these subsections of neurological society where there is one section of autoimmune disorders, and that subsection can take this up and through the IAN can approach the ministry for this to be done. So we'll have to find out who are the office bearers of the subsection at the moment. If you go to the IAN website, Indian Academy of Neurology website, all office bearers of the subsection have been written down, and one could approach through them. Now, unfortunately, my tenure in the IAN is finished now, but
Okay.
IAN is an active body, and I can always
Oh,
talk to
that'd be
whoever is the
wonderful, sir.
concerned person.
We can do that as an
Certain,
advocacy. We can actually
yeah,
take it up.
just
So,
yeah. Just let me
so
know who it is and send them a letter and let me know. I will pursue it. Yeah.
sure. So the government has been sending out directives about Ayush, officially. We are
Hmm.
allopathic, we are practicing modern medicine, but somewhere I also feel that where diseases like multiple sclerosis, and because in Kerala they are actually claiming that the Ayurvedic system does help in keeping MS symptoms under control. So can't isn't it time that if we have got an Indian system of medicine, isn't it time that there's an amalgamation of modern medicine and the Indian system of medicine?
I think you
Isn't it?
brought out another fantastic point: holistic medicine. I think we all internally realize that holistic medicine is important and all the different sciences must work together. But in MS is one disease where the society could take this up and design a model for amalgamation. Like, for example, the Kerala people can do what they're doing, and an allopathic doctor can keep on checking the clinical signs and EDSS and do the MRIs and actually show that it helps. In today's world, you have to prove with evidence that it works, but that should be possible. So I think that's again a very, very good point. I think again we lost Dr. Bhatkandi. No? Hello? Hello?
So seems like we.
Yeah.
No.
So we'll wait again.
My the thing, it was my fidgety finger which took me off.
Yeah.
I'm sorry about that. Okay.
So
You,
as I was saying, I think if the MS Society takes it up, let
yes,
the a Kerala Ayurvedic practitioner give
yes,
what he gives, and an allopathic doctor in Kerala looks at the EDSS, looks at the signs, then does MRI, and actually proves in a certain group of patients that it works, that will be the beginning of
Right,
using
sir.
those therapies, holistic
Right, sir.
medicine. Yeah.
Right, sir. So, sir, we are now going to request you to officially, instruct us as to how MSSI should go forward, both in amalgamating different streams of medicine, as well as about this whole disability certification. I
Yeah.
think
I
it's so
think the
necessary, sir.
yeah, yeah. I think these are just my thoughts as I'm getting them
Yeah, but
together.
I
I'm
think
gonna
those are
sort of
very
prepared
important thoughts. Very
prepared
important thoughts,
everything
sir.
on that. So
Yes,
spontaneously, what's coming to my mind is we have to work through the government.
yes.
So the only government institution that will give certificates for neurological disabilities is JJ. So approach the JJ through the MSSI. I will speak to the current head of the Department of Neurology.
Wonderful.
If,
Thank you, sir.
if Dr. Kamlesh Jagiasi is the current head, so
Right.
let me know when the MS Society wants to meet him. I'll have a word with him, and
Wonderful.
and from there, I think let it come to the medical administration at JJ. Once
Right,
JJ does it, everybody does it. The second approach will be for MSSI to make a plea to the autoimmune subsection, MS
right.
subsection of Indian Academy of Neurology, that the disability certificates need a change, and can you help us? Again, let me know who is the office bearer, and I'll speak to them,
Oh,
and
wonderful.
we'll sort of take it from there. And
Right.
as far as amalgamation is concerned, we must first identify one or at the most two methods which have
Yes.
claimed benefit,
Right.
and then allopathically analyze them when they're being done. Uh,
Right.
this will need a research grant and everything. So it'll have to either go through the
Right.
MSSI or through some other research funding body, ICMR,
Right.
DST. They're all happy to support good projects.
Right.
So I
Right.
would think spontaneously my thoughts are going like that, but I'll think more about it.
Right. So we've got a few minutes more. So I would just like,
Yes.
on behalf of everybody, to know what is the new, what's happening in the MS field. Is there anything new happening, either where the drugs are concerned, where no resilience is concerned? What's happening? What's new
I
for
think
MS?
these few years have been marked by new and new drugs. So many monoclonal and oligoclonal antibodies have come that a plethora is available, and is now expected that in the coming few years there will be more drugs. The newer drugs are expected to be more efficacious and less toxic. So
Oh,
the field is moving very well in terms of drug therapy. Understanding pathophysiology and drug therapy, that's where the movement is. And I think I'm quite optimistic that something sooner or later will hit much better than the way it is now. Yeah.
wonderful, sir. But what do you feel about the presence of MS in India today? Because I know you must have also been told by Naushad Wadia way back when that it's not a disease of Indians. So what
Yeah,
do you
yeah, yeah.
feel is happening
Oh,
today
yeah.
where MS
See,
is concerned?
yeah. See, actually, we've come a long way there. When I was studying neurology, just as you said, Dr. Wadia used to say that I don't even know whether MS exists in India, and if at all it exists in Parsi.
Yeah,
That is how
true.
what he used to say. Because
Yeah.
the first couple of patients that he had, some three patients or something, were Parsi people. Then it went on. More people were there. There were people who were from other communities. So Professor Singhal started believing that MS exists in India in beyond Parsis also. And they both published some manuscripts to that effect. But at that time, it was thought that the disease is imported from some cold country where it exists. So we used to ask people in first 15 years of your life, where did you live? Did
Okay.
you go
Wow.
to England? Did you go to America? In America, where were you? When did you come back? Things like that. Then came the MRI. And the MRI really made the revolution. Before the MRI came, the Indian doctors had said that there is a Asian variety of MS or an Indian variety
Okay.
of MS, which is called
Okay.
opticospinal form. And when MRI came, we suddenly realized that MS in India is just like anywhere else in the world. And what we were calling opticospinal MS is actually a different disease. It's the neuromyelitis optica, for which the NMO antibody later on got diagnosed. So the MRI helped diagnosing MS. And then awareness of the MS increased amongst neurologists and up to a point in physicians. So the diagnosis became easier. Once the diagnosis became easier, more cases started coming to light. So we currently stand at a point where we don't know whether in every decade the incidence of MS is increasing or we are only diagnosing them better because our armamentarium has improved. But if you go by some very hard data that Japan has maintained, Japan has a fantastic data system, and they have shown that decade to decade, their MS graph has gone on increasing till it has reached what is there in the West, and it started where India is.
Okay.
So it's possible that we are going the same way. And we don't know whether it's industrialization, whatever. But there is a possibility.
But has there been a shift in the age shift? That means is it still being seen in young only, starting more in the young, or is
it's
it
still more in it's I think the profile hasn't changed, but because of the MRI availability, you're seeing it in older ages also or very young ages also. That's because you're thinking that this could be MS,
right?
And then investigating.
Right.
Still, I think India is rural and urban. I mean, there is
Right.
India and Bharat. Really speaking, there is India and Bharat. So, for one diagnosed case, I think there are 20 undiagnosed cases. That's my feeling. So, the load of MS in India is not very low, but is still under recognized.
Right.
Even in medical fraternity, also, there isn't that much awareness even now.
Right.
So when you talk to the general practitioners, some of them don't know what MS is, how to diagnose it, when to do an MRI. So awareness at the community level, awareness at the physician level, awareness at the nursing level,
right,
still has to be continuously done. Where I think the MS Society has a very important role to play.
Wonderful role.
Yeah.
Sir, it's been an absolute pleasure. And I'm sure all our MSPs have really benefited from this. Now I will ask Isai, the back, Jayesh, will one of you take over? Amrita? Yeah. Okay.
Before they take over, let me say that I enjoyed the interaction. I think your questions were terrific. And the interaction was very stimulating. So it was a great 1.5 hours.
So we were determined to pick your brains today.
No, I enjoyed it. I got some more things to think about now.
Yeah. Okay. Ken.
Aparna, up to you.
Aparna.
Yes, ma'am. I hope I'm audible. Thank you so much, Rekha ma'am, for such wonderful questions. I think the way you put it up also made a lot of difference to sir. And sir, it was a pleasure having you here. You have been patiently and very concisely answering each of the questions, and I'm pretty sure that any medical terms, any scientific content that you put up, you put it in a way that anybody, not just pharma, everybody could understand it so well. And you took it to the level where you could even talk in the regional language like Marathi and make it concisely possible to understand for everybody attending here. I can't thank you enough for that. And thank you so much, Rekha ma'am, for taking that effort of putting all the questions together. Thank you so much, both of you. It was a pleasure having you for us. Thank you so much.
And I think before we close, would like to thank ISAI for doing this. Even though I'm not part of the MSSI now, on their behalf and on my behalf, let me thank you for taking the efforts to do this program. And the MSSI, I must say a couple of words about them. That's one group that is so vibrant.
Yes.
I work with so many societies, but I've never seen such a wonderful group. And about the patients, I've never seen such well-informed individuals. I don't know what is with this group. They know everything. They know the medications, they know the problems, they know everything. This is a very, very well-informed group. So it's always a joy to interact with them because they know where they stand and what should be done. So overall, it's been fantastic. So thank you very much again.
Thank you so much.
Thank you.
Thank you. Thank you and bye all of you.
Yeah. Bye, sir. Thank you.
Bye, sir.
Thank you.